Tata. Hello, this is Dr. Ganesha. I'm coming with the examination of the spine. That's the lumbosacral spine. Examination of lumbar spine starts with the gait. First, ask the patient to walk and see how the gait is. So, observe the gait. See for while walking, see for the levels of the shoulder and see for the level of the anterior leg spine. And can you walk back, please? While walking, just note about any eye-stepping gait. Eye-stepping gait is that the patient lifts the leg and puts on the ground. This is eye-stepping gait. Usually it is seen in sciatic nerve palsies where there is a nerve or component involvement. The Alderman gait, whenever there is a stiff back, usually the patient walk with a stiff gait, something like this. This is Alderman's gait. In Alderman gait, it suggests you of either infective pathology. Most common is infective pathology. In that, tuberculosis is more common. And the second comes is in an acute disc, where because of the stiff back, the patient can walk with the Alderman gait, but it's less common compared to an acute infection. Then comes the waggling gait. Waggling gait is when the patient has a bilateral gluteus medius palsy. The patient walks with this gait. This is waggling gait, and it's mainly suggestive of ear pathology rather than spine pathology. Now, coming to the local examination. Usually the spine is examined in both from the front, back, as well as from the side. From the front, can you stand here? Can you stand here? From the front, see for the level of the shoulder, see for the sternum, is there any factus excavator or pigeon chest, and see for any deformities in the front. From the lateral, from the side, see for any kyphosis. Kyphosis is the forward bending of the spine. So see for any kyphosis. And from the back, can you turn and see for any scoliosis. Scoliosis in the spine. In the scoliosis, there will be a convexity towards one side and concavity to the other side. Whenever there is a convexity, that side shoulder will be elevated and the other shoulder will be drooped down. So the level of the shoulder is again important in making the decisions in the disease of the spine. And see for the level of the iliac crest from the back. If the level of the iliac crest is same, again it varies in different conditions like kyphoscoliosis. The level of the iliac crest may vary. That is one. Now coming to the back examination as such. See for any changes, any deviation of the neck towards either the lateral or either the right side or the left side. And then see for the skin changes. So look for acute inflammatory changes or the chronic inflammatory changes like sinuses or scars, or in acute inflammatory, the redness or the swelling in the spine, in the center of the spine as well as in the paraspinal areas. The next is see for any tufts of hair. Usually you can get a tufts of hair in the lower lumbar region or the sacral region, which is suggestive of spina bifida acuta, or if there is a swelling which is pulsating, which indicates the meningomyelocele. Those are the things which need to rule out in the congenital deformities of the spine. And sometimes in cases we can get a step in the lumbosacral spine or in the lumbar region, which is suggestive of a spondylolisthesis, that is called step sign. These are all inspected findings. And also when there is a step sign, you see for a band which is going to the front of the abdomen, that is called furrowing, which is classically suggestive of spondylolisthesis of grade more than 3. And now palpation. The palpation starts, you can palpate when the patient is lying down as well as when the patient is on a couch. When the patient is in a standing position, just you can do a gross examination, look for any local rise of temperature or any tenderness. Can you lie down, please? Lie down and turn towards that side. Yeah. Lie down. Now, in palpation, after local rise of temperature, now we will see the areas of tenderness. You palpate from the spinous process. To know the level of the spinous process, one is you can take iliac crest, which is the highest point of the pelvis, which is suggestive of L4, L5, this area. You can count above or you can count below to know the level of the spine. And if the scapula is anatomically placed, which comes at the level of the T7. So that's how we calculate the level of the spinous process. So eliciting tenderness, there's two methods. One is a direct pressure to the spinous process, like this, as I'm doing now, direct pressure, anteroposterior pressure. And the other one is the pressing from the side, which causes a rotatory movement in the spine. So if there is disc lesion, when we do a rotatory compression, it irritates the nerve and patient may have pain, hence palpation. So next is coming to certain special tests like straight leg raising test, which is suggestive of nerve impingement. Can you lie down, lie straight supine position? Straight leg raising test, it has got two components. One is the active component and the passive component. Active component is the one which the patient does, and the passive component where the examiner does passively. So the straight leg raising test, first ask the patient to lift the leg as much as possible till he gets the pain. Can you lift the leg? Always measure, examine the sound side first, then the affected side. Now in this patient, the patient is able to elevate the straight leg, do a straight leg raise more than 60 degrees. So this is why he doesn't have any signs of impingement. The same thing, if the patient experiences pain at this level, say it is 30 degrees of straight leg raising test, it indicates a severe nerve compression. The most common nerves involved are L4 and L5. So this is a severe lesion. Suppose if the patient can further extend up to 60 degrees and further lifting the leg, if he winces or if he gets the pain, the stretch pain, the sciatic stretch pain. So that is again, it's a suggestive of disc lesion. So one more component in this one is when you examine the sound side, if he gets pain on the other side, that is cross leg SLRT. So if that cross leg SLRT occurs, it is pathognomonic of acute impingement syndrome. So that is about like a straight leg raising test. While doing the straight leg raising, suppose say this is affected, this right side is the affected leg. I do a straight leg raise. The patient gets the pain at around 50 degrees. Now what I do is I reduce 5 to 10 degrees and dorsiflex the foot. If the pain increases, again it is suggestive of, it's a confirmation that there is severe impingement. There is one more sign where the bowstring sign. In bowstring sign, flex the hip joint, flex the knee joint to 90 degrees and try to extend it. If the patient cannot extend further, so there is tightness in the sciatic, that is sciatic stretch is again positive. Again it is suggestive of impingement. So sometimes you get sciatic stress test, the sciatic SLRT positive in cases of sacroiliac pathology, which I demonstrated in the later part of my examination. So this is what straight leg raising. Now the spine examination should always be accompanied with a neurological examination. The neurological examination should be for the motor system, the sensory system, and deep tendon reflexes. So for examining the motor system, we need to examine both the hip joints, because the lumbar nerves which supplies the hip joint is L2-3, whereas the knee joint is 3-4 and the ankle joint is L5-S1. So each myotomy should be examined in this one. So for examining the hip joint.
Okay, start.
Next part of spine examination is neurological examination. In neurological examination, it consists of motor system examination, sensory system examination, and deep tendon reflexes. In motor system examination, it has got the different components. One is the bulk, for the bulk of the muscles, the tone of the muscles, and power of the muscle. So in the bulk, we need to see which group of muscles are wasted, whether the flexor group, extensor group, or the adductor, or whichever group of muscles. We need to know which group of muscles is wasted. The wastage can be also measured by using a tape, the circumferential, the girth can be measured. I'm not going into details of this. The bulk of the muscle is to be measured. Next, the tone of the muscle. The tone of the muscles, just flex passively, the flexion and extension. Do this movements. Suppose if there is a hypertonia, the patient, the flexion or the extension will be very difficult. If it is a flaccid, it will be more free movable. So that's how we differentiate between the stiff, the hypertonia and hypertonia. Next is power. Power, it needs to be examined in all the components. Say for the hip joint, there is flexors, extensors, abductors and adductors. For seeing the flexors, you need to flex the hip joint and the knee joint and ask the patient to flex towards the abdomen. You can pull your leg and try to resist. So I'll pull it, you try to resist it. So if the power is good, the patient will resist my pressure. So the same like the extensor can be examined, ask the patient to straighten the leg. Can you straighten this my hand? See for the power. The same thing needs to be compared with the opposite side. Flex, extend, extend, extend. Flex now. Flex the knee joint. Hip joint. Pull towards your abdomen. Pull towards abdomen. Pull. Now the same thing for the knee joint. Abductors. Now we have measured about flexors, extensors. Now abductors. Can you widen your and try to resist? So these are the abductors. So it's grade 5. Adductors, can you bring it towards your? Yeah. Adductors are 5. So it is grade 5. So next is extensors. Sorry, knee joint. Knee joint. Can you straighten your leg? Can you straighten your leg? With force. Yeah. Now flex the knee joint. When your knee joint. Yeah. It's again grade 5. So like this, we need to check the power of the knee joint. The same thing we need to do for the ankle. Flex it, cross it. Hold it tight and try to resist my push. Now press my hand. So these are the ankle flexors. So now individual muscles of the foot to be examined because the most common nerve involved is L4, L5. So you need to examine the L5 component like EHL, that is exersalis, exersagitor, flexalis and flexagitor. To examine the flexalis, try to hold the great toe towards your side and I'll push it, you try to resist. Hold it tight towards your side. Yeah, I'll try to resist, I'll push it. So this is how we examine for the exersagitor. The same thing, ask the patient to press your toe down, flat and flexor. And ask him to resist for the, again, the flexors of the foot. So that's how we examine for the power of the muscle. For the sensory, the next part of motor examination is tendon reflexes. For the tendon reflexes, you need to see the patellar tendon reflexes and the ankle reflexes. So first you look for the patellar clonus. Suppose if it is a grade 3 and above, you can get a patellar clonus, which is suggestive of higher motor neuron lesion. So to elicit the patellar tendon, hold the superior pole of patella and try to push it suddenly. If there is a patellar tap positive, patellar clonus is positive, the patella goes to and fro like this. So that is patellar clonus. The same thing you can elicit in the ankle joint. So flex the knee joint for 15 degrees and hold the foot. So suddenly give a jerk to the ankle joint. If there is a patellar clonus, it moves in this way. So that indicates there is a hypertonia is there. So if patellar clonus is there, so no need of doing a deep tendon reflexes. Suppose if it is not there, then you need to do a patellar tendon reflex. So you flex the hip joint, ask the patient to give the weight lie down freely with a relaxed thing. The patellar tendon should be taut. So then with the hammer, try to hit the patellar tendon. So if the patellar, you can see, you can appreciate there is a patellar tendon is contracting. So same thing do for the ankle joint. Flex the hip joint, knee joint, abduct it and hold the great toe. Slightly stretch the tender Achilles and hit over the tender Achilles. So you can see the ankle reflex is positive. So this is about the deep tendon reflexes. So now coming to the sensory system. In the sensory system, we need to examine the dermatome level. So usually the lower limb starts with L1. So L1 starts with the groin, which measures about one palm breadth. So if you start with the lateral aspect, it goes towards the medial aspect. This is L1. Just adjacent to that one palm breadth is L2. Then again L3. So over the knee and the medial aspect of the leg is L4. L5 over the lateral aspect of the leg as well as the lateral aspect of the foot. And there is the autonomous zone in the first rib space. S1 is the sole. Then it continues into the posterior aspect of the calf. S2 from the thigh, and S3, S4 where we in the gluteal area, that is perianal areas where we sit. So that's the dermatome levels. So dermatomes need to be examined with a wisp of cotton. For the pain, you need to examine with a pin. So and temperature also. The all three modalities of sensation. Examine. Now the third part of spine examination is the sacroelectronic examination. To know the sacroelectronic, first we need to see from the back. Can you turn this way? The dimple of Venus suggests dimple of Venus is an anatomical landmark for the sacroelectronic. See for any tenderness in the sacroelectronic. So now lying down supine. So even in the sacroelectronic you get example, but you need to differentiate whether it's coming from the sacroelectronic or lumbar disc lesions. So for that there are certain tests which can differentiate. One is the Patrick's test or the Faber's test, where you press the hip joint and the knee joint, abduct it and externate it. That is Faber's test. So press over the knee joint and with the other hand you stabilize the pelvis. If the patient has got a sacroelectronic disease, the patient will have pain. So this is how to differentiate the sacroelectronic. Other tests are, one is the compounder test, just to confirm that sacroelectronic pathology. You press the hip joint and knee joint and adduct it, and you stabilize the trunk with the other hand. You give a pressure to the knee joint. See for any pain. So if the patient has got pain, it indicates sacroelectronic pathology. The other test is Jensen's test. In Jensen's test, what you do is ask the patient to come towards the edge of the couch. Can you come towards the side and drop the affected leg towards the floor and lift the other leg. If the patient has got sacroiliac pathology, the patient will have pain on the limb which has been kept hyperextended. So this causes a rotational movement at the sacroiliac joint, which indicates pathology in the sacroiliac joint. So this concludes my spine examination. Thank you.